Hi all, Dr. S here, Cardiac Meds Part 3. This will wrap up the voiceovers for cardiac medications as they relate to the concept of perfusion and our exemplars or cardiac disorders that we will be discussing in the next 3 weeks. So today we're going to talk about calcium channel blockers and diuretics. And so I'm going to go ahead and get started with calcium channel blockers. So we've talked about beta blockers in the voiceover for medications, voiceover number 2, and finished up with the beta blockers. So the other one is the calcium channel blockers. They end in pine or pene. They work primarily in the heart muscle. So as a recap, your ACE inhibitors and your ARBs indicators are specifically managing blood pressure in the kidneys. So you must have good kidney function. So you should be well aware of your labs to evaluate and vital signs to collect prior to giving. And then your beta blockers, 1, your non-selective beta 1 blockers, and 2, especially 2 only if they have non-COPD asthmatic underlying respiratory disorders work in the heart muscle, and the calcium channel blockers work in the heart muscle. So the action of the calcium channel blocker is to block the calcium's access to the cardiac cells. That's going to cause a decrease in contractility and decrease in the arterial constriction. By doing so, reduces peripheral vascular resistance and therefore decreases blood pressure. So once again, with the concept of perfusion, when you have somebody who has high blood pressure, let's say secondary to long-term smoking causes vasoconstriction. And so you have to dilate the peripheral vascular system in order to improve blood flow to lower extremities and your organs throughout your body. So to do so, this particular medication blocks the calcium, which normally would cause vasoconstriction. But with this patient who's a smoker, you have increased vasoconstriction due to the smoking. So by blocking the calcium, I am going to be able to have a vasodilation, which means improving volume and decreases that vascular resistance that's caused by smoking. So that is the reason why someone could be on a calcium channel blocker. Indications for this is hypertension. We can use it for patients who have vasospastic angina. It also can be used with classic chronic stable angina. So don't jump ahead and listen to this content before we talk angina, hyperlipidemia, or antilipids and erectile dysfunction, which is next week. Can be treated for AFib or flutter, as well as treating migraine headaches because you're improving vascular resistance. You're causing dilation to the brain, and that can help improve blood flow, which could also help migraines. You can consider that maybe an off-label use. There's enough migraine meds on the market that they would have to be completely exhausted for the most part, I think, before a PCP would a provider would put someone on a calcium channel blocker. So there's a lot of these medications, these pine medications that can be used as a monotherapy or can be used in conjunction with other types of antihypertensive medications. And when we talk diuretics, you'll see how diuretics will reduce volume by allowing us to urinate out excess fluid. So in addition to diuretics and antihypertensives, they all have different mechanisms of how they work in either our kidneys or our heart, but they have the same outcome, which is to improve blood pressure, decrease resistance, and reduce volume fluid overload. We do not typically recommend its use with severe folks who have severe congestive heart failure. The heart's already having trouble managing contractility. The pump of the heart is not contracting well. So if this medication is going to decrease the contractility, why would you use a calcium channel blocker for someone who is in severe CHF, like end stage? You may see it used in the early stages of CHF, but would be contraindicated in the later stages. CHF is typically not reversible. It is managed with pharmacological interventions, diet, and cardiac exercise. We wouldn't use it necessarily with second or third degree AV block, and you cover that content in 211, so you need to bring this forward. You would not seriously recommend it for someone who has a systolic blood pressure less than 90, already has a history of bradycardia. And you would definitely use it in cautions with the elderly client because it has a long half-life. So it's usually given once a day. And so for the long half-life could be up to anywhere from 18 to 24 hours. And so the elderly are already compromised due to just, a normal aging process with, let's just say, with no existing underlying cardiac or kidney disease. They've managed a healthy lifestyle. That doesn't, with calcium channel blockers, you have to be careful. Some people respond very well and some people don't, and some people, based on their background and their history and certain underlying cardiac conditions, as I noted, severe CHF, a history of bradycardia, if they have a pacemaker to regulate heart rate, they shouldn't be having a calcium channel blocker as part of their diet. Undesirable effects, well, you don't want them to have hypotension, so you don't want to overdilate their peripheral arterial system. They can have a headache because you've overdilated. They can have dizziness. It can, as I noted, can worsen congestive heart failure, which will lead to peripheral edema, so lower extremity bilateral pitting edema, where we are retaining fluid in interstitial spaces, or what's called third spacing. We're not supposed to have fluid in those parts of our bodies. Can cause constipation because you're pulling fluid into places it's not supposed to go, like lower extremity edema, JVD, jugular vein distension, edema of fluid in the blood in the lungs. That's not where stuff's supposed to be. The heart is not pumping well enough to provide a vascular perfusion to where the blood flow is supposed to go. Other information that's important to be mindful of. I did warnings, I'm sorry, undesirable effects. So interventions, monitoring, obviously, liver and kidney function. These people need to be on tele, as I said, with patients on beta blockers. We need to monitor rhythm and rate of heart rate and the electrical conduction of their cardiac cycle. Potassium, sodium, magnesium, and what's the other one we talked about the other day? Calcium channel blocker. If someone has a hypoparathyroidism, which manages your calcium levels that you learned about in 112, and we can't regulate calcium, these folks shouldn't be on calcium channel blockers. All right. Definitely don't use if a patient has a second or third degree atrial ventricle block. I'll leave it at that. Periodic potassium levels need to be drawn. You always have to have calcium available if for some reason the doctor has them on and their calcium levels drop. So liver functions is just a given. Kidney functions is a given, but your electrolytes definitely, especially your calcium and your potassium, have to be monitored. Protect the drug from light and moisture. Position client to decrease peripheral edema and refer back to the mnemonic for pressure. Okay, so basically what I talked about in the previous voiceover number 2 as it relates to beta blockers. Education, because of the constipation potential risk for, instruct your folks to increase dietary fiber and fluid intake and exercise. Avoid overexertion. So go back to the indications. We can use this for vasospastic angina, which I'll talk about. And I'll also talk about chronic stable angina. Someone can have stable angina and it be chronic, and we manage that with medications. Stable angina is when folks have too much exercise. They exert the heart muscle, and it causes chest pain. And when we stop the exercise, the chest pain resolves because we don't need the increase of oxygen consumption, which would increase our heart pump. So the chest pain goes away. But we may need, because of the angina, the blood pressure is going to go up and the heart rate is going to go up. So calcium channel blocker can be used in situations like that. So it has a couple uses besides treating hypertension. Encourage to take with meals or milk. If it's crushed, don't crush the med, don't chew it with those sustained release tablets. That's what you learned in 117. And this is definitely advised to avoid drinking grapefruit juice. Evaluation, we want the blood pressure to be within normal limits. We should have sinus rhythm on our EKGs. If administered for angina or headaches, there should be a decrease of symptoms. So some of the drugs that you might be seeing already on your units, Norvasc is amlodipine, benazepril is Lotrel. You have valsartan, you have dilancium or cardizem. You may see Plendil, suspended or sustained release. So typically it's your pines is the language that you see regarding your calcium channel blockers. So I missed the screen. Let me go back. So we have to do with one of your acronyms that you can work with is the major undesirable side effects that are specific to your calcium channel blockers. And that is I don't give a flip pill. And the reason behind that is because many of the undesirable effects of using a calcium channel blocker is the most common is the headache. Hypotension is also very common, and syncope. Syncope is causing the heart rate's going to slow down and the blood pressure is going to go down. So people are more prone to dizziness and lightheadedness, increasing peripheral edema, bradycardia, and constipation. So we don't give a flip because it causes syncope and they're just feeling blah because they're constipated, because they have a headache and they feel under the weather because they have abdominal fullness. So when you look at irritable bowel syndrome, for example, folks that may be on a constipative side, I'm not talking inflammatory bowel, which is relevant of UC and Crohn's. I'm talking irritable bowel, where folks can have diarrhea or be significantly constipated because of that underlying GI problem. You don't definitely should not be on a calcium channel blocker because it's just going to make them feel worse, more blah. So again, the most don't give a flip pill is because of the syncope, hypotension, headache is very common, and constipation is very common. So be mindful of those. Vasodilators now. So we're going to talk about the vasodilators and what exactly is a vasodilator. It's direct action, dilly dilator. All right, dilly dilly. If anybody watches morning show with Hoda in Savannah. Dilly Dilly, she does the weather for once in a while. So the action of a vasodilator. So these kind of medications, for example, are aprezoline or hydralazine. You may see these because folks have really high blood pressures. We even see it on a GI unit on 3VPN. So they're very common. You'll have parameters on it. For example, if somebody's systolic is probably, I'm going to say 160. If their diastolic is greater than, I'll say 120, that is, you're getting into stroke territory. So you may see the aprezoline on CPCU, for example. You'll definitely see it in more cardiac critical care units because we have to manage blood pressures for whatever reason are significantly elevated. When you think about learning about strokes in 211 in the fall, one of the most common causes of a stroke is uncontrolled hypertension. So vasodilators do direct relaxation of vascular smooth muscle. And that just decreases produces vasodilation and decreases afterload. So again, go back to your cardiac cycle. If you use any of those RN supplements, YouTube videos, I did post a few extra ones, but you know your learning style the best or what's been working for you. You need to know preload and afterload because the afterload is important as it relates to the vasodilator. Indications is for significant severe hypertension. Warnings, we don't use it with people who have coronary artery disease, and we'll talk about that next week with coronary artery disease as it relates to increased cholesterol levels, plaque buildup, people who have genetically predisposition to hyperlipidemia. We don't do that because they've got so much blockage already that you're forcing the smooth muscle to relax. And when you do that, you can dislodge plaques and cholesterol and throw a clot. We don't use it with rheumatic heart disease. You don't do it with someone who is pregnant and already has impaired renal function. And it's not used for folks who've already had a CVA or a cerebral vascular accident, aka stroke. So this is primarily to make sure that you understand if someone has underlying coronary artery disease, a previous CVA, or has a poor BUN creatinine and less than 60 GFR, you definitely should be talking to your docs. So a lot of the times these hydralazines are PRN on a non-cardiac unit per se. Undesirable effects, well, think about vasodilating somebody out. You're going to drop their pressure. So headaches, they're going to vasodilate. It's non-specific, which means it dilates everything. So you get a headache, dizziness. They could be palpitations, tachycardia, because if you're tachycardic, because you're hypotensive, you dilated the whole system out. So your peripheral volume drops and your heart's going to go into increasing its heart rate because it has less volume to work with. But that's kind of what you expect to happen. But at the same time, we have to be careful with the tachycardia. You don't want them pouncing around at 140 because that could cause a rhythm disturbance. So just be mindful of those things. Can cause edema and or weight gain. And when you use it in conjunction with, we'll talk about diuretics shortly, you're adding diuretics to someone you've dilated out, and then you're perfusing excess volume. You're going to make them extremely hypotensive, and they're going to have a problem, significant problem. They, of course, should be on a tele. So obviously, any interventions with anything I've talked about, they should be on a tele, monitoring blood pressure and heart rate before giving, and within a half an hour. If they're symptomatic, you should be checking orthostatics, lying down, then they sit up, wait a few minutes, take their pressure. You need them to have an equilibrium when you move them in certain positions. When they sit up, they're going to drop the volume in their brain. So you want them to wait a few minutes. You get a real value on that orthostatic. Dangle their legs and have them stand up. If they're too dizzy to stand, don't stand them. You did that. You don't need to confirm with objective data that they're too dizzy, because if they fall on you, that's a whole different nightmare. Nasal congestion. It's just vasodilators are just not a fun drug. You know, they're just pretty harsh on the kidneys, and they're pretty harsh on the peripheral system. But you definitely, if you're on it, refer back to pressure. Definitely, we're doing blood pressure, heart rates. We're getting daily weights because of potential fluid loss. We want to teach these patients to check their heart rate. So I have seen people on hydralazine out in the community in my home care days. They're just on a really low dose, and that just means they've tolerated the drug well and it works for them, and they don't have those kind of symptoms that cause those undesirable effects. But you need to know what they are, because that med just may not be the drug of choice for that patient. Same can be said about mental health drugs. You know, you just had a reaction to Zoloft and you have extreme insomnia, and that's not going to work for you. ACE inhibitors, you're on a lisinopril, Prilsister, and you're just one of those unfortunate folks that has that dry hacking cough that will not go away, and it's so undesirable that the doctor has to take you off the ACE inhibitor and put you on something else. So again, it's just not every drug works for every person. So Pregabalin can be used out in the community, but you want to educate your patient. They need to be checking their blood pressure and their heart rate. They have to notify their provider if they have a 5-pound weight gain, if their heart rate is 20 beats over their baseline. So let's say they're running 80 and all of a sudden they jump up to 100. Definitely if they have any fevers, any weight gain, any muscle or joint pain, that could relate back to just feeling achy and crappy. Can cause constipation, and GI upset, nausea, and vomiting. So they need to eat unsalted crackers. But by then I'm on the phone with the doc and saying, I'm not sure this is the drug of choice for this folk. They're having a lot of undesirable effects. So exactly what is dilly-dilly? D stands for directly acts on the vascular smooth muscle, causing vasoconstriction. It increases renal and cerebral blood flow. So it's really perfusing. So those of you who have already done the CHF sim with Mrs. Steen, and if those that haven't yet gone and done that, when you get in and start talking about digoxin, what does digoxin do? All right, it improves perfusion by improving the force of contractility. So the heart has more of an effective beat and it's not working as hard because the muscle is tired. So you want a more forceful contraction. When you do that, you're pushing oxygenated blood flow to the kidneys. So when Miss Mary comes in and says she hasn't peed since she's been at the hospital, it's because her kidneys aren't perfused. The kidneys aren't making urine. So you bladder scan her, she's got urine sitting in there, but you need to give her the dig so she starts producing urine because you're giving her the Lasix. That's the trick of dig. The same can be said about the vasodilator. You're increasing the renal and cerebral blood flow. So by increasing renal blood flow, you're increasing perfusion to the kidneys, and you're going to get that diuretic type of outcome. All right. You're going to get that headache. All right. Um, the L stands for like a reaction to fevers, facial rash, muscle and joint pain. A is always assessing for peripheral edema, especially not only in the feet, which is where we would see it because gravity pulls everything down, but also in the hands. So you want to be mindful of that as well. We elevate the patient's legs and try to put the toes above the kneecaps. So that makes me think that, they're getting some elevation to pull the fluid back up. And we'll talk about vascular resistance in class. Take the medication with food. The O stands for the other undesirable side effects: headaches, dizziness, not really hungry because of the nausea and the disturbance of maybe being vomiting, tachycardia, and hypotension, and always review blood pressures. All right. So diuretics, we're going to spend some time on 3 types of medication that you will need to know. But let's talk about the concept of the diuretic itself. The diet, specifically, because you're changing your parameters now of how you consider the use of diuretics. When you think about a diuretic, what are you thinking about that patient's presenting with? They have excess fluid in places in their body it's not supposed to be in. And typically it can be due to congestive heart failure. And that's how we typically present that in class, is to give you a black and white scenario of a patient with CHF, so you can apply the concept of diuretics, and then we can talk about different kinds of diuretics and where they work in the body and what specifically, therefore, we need to be managing in sense of undesirable effects. And I spelled review wrong here, so my bad. So basically, with the concept of diuretics, we want folks to be instructed diet-wise to eat a low-sodium diet, but a diet rich in potassium. Clients that take potassium-sparing diuretics should not eat a diet rich in potassium. So let me back that up. A diuretic that spares potassium, in other words, we're not urinating or peeing out potassium. We're keeping potassium like our kidneys should be doing. So don't encourage them to eat foods that are rich in potassium. You need to know what foods are rich in potassium: bananas, dark green leafy vegetables. Is there lean meats that have potassium? So these folks need to be on a low sodium diet. And not only that, but what does sodium do? Sodium and water, they love each other. So the higher the sodium diet is on a bad heart pump, it's going to retain fluid. So you want a low sodium diet. You need salt in your diet. But folks will most likely be A, on a fluid restriction, and B, be on a low restricted, some type of low sodium diet indicated by the physician. That is an order. We can't walk in the patient's room and recommend a low salt diet. We need an order from the physician. And then I highly encourage you to get a dietitian, cardiac educator, one and the same or 2 different people, to come in and have that conversation with patients. How do you read a label? What foods are high in sodium? Your box frozen foods. Anything that's canned is a preservative. The best thing in the world is lean meats. Stay away from your animal fats, your beef, your livers, your processed foods. Hot dogs are horrible. Macaroni and cheese, anything that's boxed, anything that's frozen. So that people want, fresh veggies, fresh fruit, have the money to buy good olive oil, skim milk, anything that's dairy should be limited. So you tell me what population can, manage that on a week-to-week basis. And then you can let me know why we have so many people in the world sick with cardiac problems. So intake and output, these outcomes that we assist in evaluating the effectiveness of the drug. So INO, you'll have a strict INO. These people aren't going to have IVs running if they have CHF. They're already in fluid overload. So you're not going to have an IV, but you should have a saline lock. If you don't put one in, you need to, because these folks are probably eligible for IV push Lasix. Because that's the fastest route of administration. We want to get it in there and get fluid off. Of course, they'll probably go home on a diuretic by pill, because that's the way that they manage this symptom or this disease in the community. So you have to have intake. So you would need to be measuring how much food goes in to their body, so that we can measure how much output. The output is the most valuable, because if you're giving them a diuretic, whatever they put in, that output should be an equivalent to the intake. If you're getting less output than the intake, they're holding on to fluid. Okay, and therefore you should be hearing that respiratory compromise, short of breath with activity, needing oxygen supplementation, typically 2 liters nasal cannula without underlying respiratory comorbidities. You would see peripheral edema. So that tells you because we have a tool to measure intake and output, we have to be very sound. You can delegate that to your CNAs. Folks may have an indwelling Foley catheter for the primary purpose of measuring output. Cause and effect of putting a Foley in to manage cardiac compensation and fluid overload for me is a perfectly realistic and expected intervention. You just have to be extremely sterile with your insertion of the Foley. But that will trump putting a Foley in because I have to deal with Maslow's airway breathing circulation. So I would not question a Foley insertion. I would go with a PureWick, making sure that it's effectively placed and I'm getting appropriate output into the canister. But that requires significant diligence to ensure that PureWick is appropriately placed. Whereas with the Foley, it's in and it's holding its own, right? So think about those pieces when you're talking critical thinking. So the outcome in the evaluation of the drugs is to increase the urinary output. So these folks may be thirsty because they're also in a fluid restriction. So hard candy, sips of water, sugarless gum may be effective for dry mouth. So that's really important. So the undesirable effects are the following: fluid and electrolyte imbalance. You have to monitor fluid and electrolyte imbalance. Folks can have hypovolemia. That's going to increase your heart rate. They can have increased respiratory rate. They'll have a blood pressure that drops and an output that drops. They're hypovolemic. Hypokalemia, and we'll talk about Lasix and furosemide, for example, is not potassium sparing. So it's going to pee out potassium. So they're at risk for hypokalemia. Orthostatic hypotension. You can have medications that can cause hyperkalemia. So we need to be mindful of what kind of diuretic they're on, and we'll talk specifically about that. Therapeutic range of potassium is 3.5 to 5. It's a very, very small window. Folks with low potassium are going to get a potassium supplement. Folks with high potassium are going to get a medication that's going to cause them to release potassium. It's typically going to be in a stool, and the medication typically is Kayexalate because we got to get the potassium down. Remember, potassium is your primary electrolyte for cardiac electrical conduction. So if you've got an elevated potassium above 5 or below 3.5, these folks can have an abnormal EKG. That means their rhythm is off, and that's a problem. We need to definitely be mindful of causing hypovolemia. So you're taking heart rates and blood pressures. You want to set them up slowly. You want to be very careful if the client is also taking digoxin, because can cause increased hypokalemia due to the risk of dig toxicity. So what's your dig toxicity? Number one sign and symptom, nausea, vomiting. If they're not complaining of that, they may be complaining of yellow and green halos. You need to memorize those symptoms, period, end of discussion. Heart rate has to be above 60. You have to do an apical rate before you give dig. They have to have lab work and dig toxicity levels drawn daily. You have to be careful with the elderly patient with a diuretic because, as I said earlier, physiologically, as we get older, kidney and heart function does change. So we need to have accurate assessments of electrolytes and blood pressure. You definitely need making sure we're evaluating adequate renal function as it relates to BUN and creatinine clearance in the elderly. You can take with meals or after, but you want to take your diuretics in the morning. You want to teach your folks that they need to get on a blood pressure. They need to get on a scale in their birthday suit first thing in the morning when they get out of bed, and they got to empty their bladder. Don't have them taking their weight throughout the day. We put on water weight as part of just natural process. When you already got a bad heart pump, they're just going to put on more water and freak themselves out. The dry weight, they've been laying flat for the most part all night, or even at a 45-degree angle with some extra pillows, if you will. But everything's at rest. It's the best metabolic rate. So that's what you want them to do. And they want to write your weight down. If you've got a 2 to 3 pound weight gain over the course of 48 to 72 hours, they need to be on the phone with the doctor. So you definitely want them to take their diuretics in the morning. It's going to make them pee. The hardest compliance with diuretics for male and female is those that they have to pee. That's how the drug works. It works in the kidneys. So they're going to pee. So they may not take their diuretics because they're going to go on a long trip, or they're going to go play bingo with their friends. And I'm not being, you know, uh, I'm not picking games that are particular to the elderly, but you're limiting. They need to talk about how they can have maybe a diuretic holiday. The same thing we do with medications that can cause erectile dysfunction or decrease sexual libido in mental health medications. Let's talk about holidays and how that would look. And meet them halfway. How can I get you to be compliant? Because you can, every single time you go into fluid overload, your heart gets worse, and eventually it will kill you. It's not going to come back. Your heart muscle is not going to come back. So we definitely want to be mindful of that. Don't have any alcohol. The alcohol products increases diuresis, causes us to void more because it puts your liver in overdrive. And so when you increase your metabolism, you're also increasing renal function. So, if you sit back and have a couple beers at a baseball game, I'm just using an example, you find yourself having to get up and pee more. That's just because that's what the alcohol does. But that's going to cause an enhancement to the diuretic, and so that can increase your risk for hypotension. So what does the D stand for? Make sure that we're increasing potassium in patients' diets, unless it is a not a potassium sparing. Intake and output, daily weights. Have to manage fluid and electrolyte imbalances, review heart rate, blood pressure, electrolytes, be very careful with your elderly, take with or after meals, and in the morning, increase risk of orthostatic, so get around slowly, and C is cancel alcohol. All right, loop diuretics. So your loop diuretics specifically inhibit Lasix is the most common, or furosemide. You may see Bumex or Demodex, but typically the EX endings or the IX for Lasix are your loop diuretics. They inhibit sodium chloride in water reabsorption in the proximal portion of the ascending loop of Henle. It's a very high potency sealing wall because it kicks in pretty freaking quick. Indications, we'll use it for folks with CHF who have third spacing edema, lungs, lower extremities, etc. Already in CHF. We can use it with folks who have cirrhosis and have abdominal ascites. And with right-sided CHF, you can see abdominal fluid retention as well, and JVD, jugular vein distension. We'll talk about right and left side when we get there in class. So we can do that. You need to we're pulling fluid off of places it's not supposed to be in, and it works in the kidneys, and it pees out potassium. So it inhibits sodium and chloride and water reabsorption. So it causes the sodium in the water and the potassium to be excreted. So warning signs, I'm sorry, I did indications, yes. So warnings, hypokalemia. So these folks need to have a PRN order for Cater or potassium, which is usually pill form. If their potassium is so low, they're going to get IV potassium. May I suggest, when you think about that, plus IV mag, and I think I might have mentioned this before, it's very caustic on peripheral IV access, your peripheral insertion sites. So numb up the areas with some lidocaine so it's not so painful and burning. Mag and potassium need to be on IV pumps. Never let it run not on a pump. So hypokalemia, renal hepatic dysfunction, and can cause, it can't cause, but it can, you want to use it carefully with folks who are diabetics. And why would I say that? Because folks in uncontrolled diabetes are going to have problems with their kidney function. So if you give them a diuretic, it may not work as well, and it's putting more stress on the kidneys. Undesirable, hyponatremia, hypokalemia, hypocalcemia, hypomagnesium, can cause alkalosis, and they can have hyperglycemia. Because if the kidneys aren't working that well, then you're going to have sugar in your system. You can have hyperuricemia. So what's that back in the day? ureic stones, kidney stones, gout. There you go. So remember, everything is decreased except the glucose and the uric acid. So again, hyperglycemia and hyperuremic, and all other labs are be hypo. So if you want to do a note card, hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia, and hypochloremic. And therefore, they'll be alkalotic. You'll get ABGs next week, I believe, with Miss Veronica. Those of you who see me in the fall, you've already had 112, so hopefully this is a review. Hypotension, blurred vision, headaches, dizziness, lightheadedness, dehydration, muscle cramps, ototoxicity. What's ototoxicity? Wait a minute. What's ototoxicity? What does that got to do with my eyes? You push Lasix too fast over periods of time will cause tinnitus. So you should always be asking your patient when you're doing an IV push of Lasix, very, very slowly, I might add. Do you have any ringing in your ears? If the answer is no, we're good. If they have ringing in the ears, you need to slow down your push. Period. End of discussion. Because if you, not you, but if you don't abide by that and they keep getting IV Lasix over time because they're just frequent flyers with CHF, they can go deaf. Let me say that again. They will lose their hearing. So do you want to own that? No, I don't think so. Monitor serum glucose. So these folks should be getting blood sugar checks. They obviously should be having daily electrolyte functions and kidney and liver functions drawn. If they don't, please get them. Report changes in hearing, irritability, any GI distress, and refer back to the word diuretic. Want to evaluate blood pressure, and is the edema getting better? We've gone from maybe +2 to +1. We got +1, we've gone to trace. Make sure you got pedal pulses. If you have too much edema in the lower extremity and you can't palpate, get a Doppler. So what is Lulu? Lulabelle. Lulabelle. Lulabelle goes spinning around over the falls. So she's falling off Niagara Falls because she has lost so much fluid from being diuresed. Her ears are ringing and she's dizzy from a decrease in her blood pressure. She has lost so much potassium in the falls, urinating so much diuretics, and that is a common cause of Lasix. All right. So we'll talk about thiazides, but ascending loop of Henle, the one common cause of severe hypokalemia, loss of potassium, hypotension, is because of the high potency of Lasix and how it works in the loop of Henle. That's why they call it a high ceiling, high potent drug. So that's Lulubelle. Thiazides. Thiazides are a little bit different. They do increase urine output by inhibiting reabsorption of sodium chloride in water, but they do it in the distal portion of the loop of Henle. Some of your thiazides, they end in thiazides. One of the most common is HCTZ, which is an acronym for hydrochlorothiazide. That is typically what I see the most common first time use to treat. Let's say a doctor doesn't want to start a patient that might have the beginning stages of high blood pressure. So instead of like a beta blocker that works on the cardiac muscle, or an ACE or an ARB that works in the kidneys, they may start them on a low dose of HTZ, because if you can pull off the volume, you may be able to decrease the blood pressure, and it may just be a diet with high sodium that needs to be adjusted. And that's all part of that collection of your family history, past medical history, diet, lifestyle, alcohol, smoking use. That's why that histories are so, pardon the expression, not burp, sorry, are so critical, is to ascertain the relevancy of the medication list that your patients are on when you reconcile. Doesn't matter what environment you work in, if it's home care, ICU, your job is to reconcile. You are the eyes and ears of the physician. Please don't feel that they know what they're doing. They do, but aren't two eyes better than one? Here's a classic example. When you go to give insulin, are you solo in pulling up that insulin? When you hand that needle to the next nurse to validate it, that's your second eyes and ears. So you're protecting yourself by saying how many units is in here. Because if they say 3 and you thought you drew up 5 and you need to give 5, you caught a med error. So hold your physicians accountable the way you hold yourself accountable. So indications for use, again, edema associated with CHF. Well, you can use it with folks who have cirrhosis, which is liver failure, and they have portal hypertension, which is ascites, and you get that in 211. And we'll use it, we can use it with some types of renal impairment. We can use it with acute glomerular nephritis and nephrotic syndrome. Because if you think about going back to glomerular nephritis, we had chronic and we had acute. Acute, the particular example that's the most common is strep throat or strep throat that it has unresolved after about 10 to 14 days of a typical penicillin course of antibiotics. And so in that discussion, they may need to be on a diuretic because remember what's happening to the kidneys, they're not working real well, so the patient's putting on weight. So they're more full of fluid due to the infection lingering and hanging on, right? And then you have the chronic glomerular nephritis secondary to inflammatory autoimmune diseases like lupus. All right, so you may see these folks can be on a long-term thiazide for lupus, and you may see them getting a thiazide if they're admitted short-term for the glomerular nephritis. All right, warnings: we don't want to give it to folks who have low potassium because we're just going to take more potassium away. If they're hypersensitive to sulfonamides, sulfa drugs, and most of your sulfa drugs are your antibiotics. And so we don't do a lot of antibiotic management in 114. Flagyl is a sulfa drug, which is an antibiotic. Flagyl is used a lot of time for GI lower gut infections like C. diff, for example. Maybe an exacerbation of ulcerative colitis, we might see Flagyl. So we have to watch these people, especially if they've got small intestine obstructions. That's going to affect absorption. And I'm sorry but you can see the holistic value. Obviously, if they have renal or hepatic dysfunction, again, we're using it cautiously in elderly clients. You're using it cautiously with folks with diabetes, gout, or history of lupus. Now, I say the history of lupus, but if it goes back to the glomerular nephritis, it's using it is a warning. It's not contraindicated. So don't look cross-eyed at me, but it's a very careful assessment of the patient. And is there a better drug that can treat that fluid overload due to lupus? Other specific information, I'm sorry, did I skip over? Undesirable effects: low potassium, low sodium, low uric uricemia, which is the opposite of Lasix, hyperkalemia, hyperglycemia, orthostatic hypotension. The bottom line is you need to managing these folks' electrolytes. They need to be staying within normal range. We need to intervene accordingly if they're not. If they are also taking digoxin, they're at higher risk for hypokalemia. And if they take lithium for bipolar, they're at higher risk for lithium toxicity. I suggest you strongly underline that and put that in red. There's an increased loss of potassium when taking corticosteroids. And when do you use corticosteroids? In the sense that you understand it, folks with COPD that are in an exacerbation and are hospitalized for it. History of bronchitis, hospitalized for bronchitis. Corticosteroids open up the airway. They're bronchodilators. And so you have an increased loss of potassium when taking that. So it's just these medications interact. So you can maybe understand looking at your medications now when you look at your patients in the next 3 clinical days, or depending upon when you listen to this, it's very important to now look at your medications and are there interactions. Education: instruct your folks to stop the thiazides if there is a parathyroid function test due to altered calcium levels. And because of the diuretics, even the Lasix, if you've got low calcium due to hypo or hyperparathyroid. So I'm bringing that back into play. Teach a patient how to check their blood pressure. Go out and buy one of those monitors. Radial pulses for folks that are on DIG, unless they can get a heart monitor. Blood pressure heart monitor, and do daily blood pressures. As I said, the drugs most commonly are HCTZ, Hydrorel, Lozol, Diarel, and are the most common ones. So why do I have Lulu Bill back up here? Because since the thiazides work in the distal tube, the major difference from the loop diuretics, such as Lasix, our calcium may be higher. And this rhymes with thiazide, so may be high. And the client experienced no ototoxicity with thiazides, the way that they would with a loop diuretic. And then we have, last but not least, our potassium-sparing diuretics. And this is aldactone. And you'll see aldactone a lot prescribed for folks that have liver cirrhosis, that have ascites as a secondary. Liver cirrhosis typically is due to the liver failing from long-term chronic alcohol use. The action of this drug promotes the excretion of sodium water, but retains potassium, and it's in the distal renal tube. We'll use it with a loop or thiazide diuretic in treating CHF and hypertension, but this diuretic holds on to potassium. So you can see both being used. These folks have to be pretty seriously sick to have them both on Lasix and aldactone, because you're putting a whole lot of work on those kidneys. So they have to have beautiful BUN creatinines and GFR. I mean, stellar day in and day out to be putting that much work on a kidney. Use cautiously, and not just a sidebarring on this one. If they have one kidney, I'd be even more cautious. I would probably even debate the use. So you can use it with the loop or thiazide diuretic in treating CHF and hypertension. Like Lasix, it would induce hypokalemia, whereas aldactone is going to hold on to it. But yeah, I think it's one or the other. And then use Cater, potassium supplement pills to offset the potential for low potassium. Steroid-induced edema. Warnings, of course, should sound pretty much standard at this point. Hyperkalemia, diabetes, if they existed because of the renal function. If they have an impaired renal function, we should be very cautious. Pregnancy-induced hypertension. So when you head into 113 this summer, pregnancy-induced hypertension, secondary could be preeclampsia. Sometimes you may this type of drug should not be used on a pregnant mom. There are other medications that are safe to give moms that are having hypertensive episodes secondary to being pregnant. There are medications to treat her hypertension, all right, that have no necessarily any adverse effects on the fetus. Undesirable effects, GI disturbances, nausea, not really wanting to eat, diarrhea, dizzy, headache, dry mouth. Can have photosensitivity, so sunglasses, strobe lights, things of that can be an issue. Definitely want to make sure that we monitor the potassium levels. These folks should be on tele because when you learn AKGs in 211, hopefully they'll go back and talk why T waves, for example, would be elevated. They are elevated with the use of aldactone, but I'm not testing you on that, but bring it forward. You can have digitalis and lithium toxicity with aldactone. Again, hyperkalemia will also increase if folks are taking ACE inhibitors. So go back and think about your lisinopril and your captopril sisters. You don't want to give them potassium supplements. There's no need to. We're holding on to potassium. Interventions, monitor potassium levels, and if they're on DIG, they need a DIG level every day. So refer back to the mnemonic of diuretic. Education, inform the client that maximum hypotensive effect may not be seen for 2 weeks. Counsel client to avoid citrus juices, colas, milk low in sodium, some salt substitutes. They don't need potassium supplements, and definitely want to monitor them for elevated potassium if they're receiving a blood transfusion. Obviously evaluating their blood pressure, their heart rate, their dizziness, lightheadedness, GI, definitely potassium levels. Edema should decrease. The drug that's most common is spirolactone, which is also known as aldactone. So what does ALAN stand for? Well, latrine, okay? So alanactone, L is for low sodium, elevated T waves from an elevated potassium, and you can only see those on an EKG, and granulocytosis, and then K levels must be monitored. So Alan is at the latrine taking a leak and getting rid of the extra volume that increases his blood pressure. And Alan is holding his piggy bank with potassium on it as aldactone helps in saving potassium. So these are acronyms that I find very helpful for students when you're learning, especially diuretics. But that does conclude the cardiac medication overview for the cardiac disorders that we're going to be talking about in the next couple of weeks. And I've already posted the PowerPoint, so I'll get this settled for you, and take good care.